The management of small bowel obstruction, a comprehensive surgical perspective. Welcome to today's podcast, where we're delving into the management of small bowel obstruction, one of the most common surgical emergencies encountered in clinical practice. In this episode, we will walk through the journey of diagnosing and treating this condition, focusing on the crucial steps needed to ensure the best patient outcomes. Opening remarks. Small bowel obstruction presents a classic surgical dilemma requiring rapid assessment, resuscitation, and decisive intervention. The primary goals in managing this condition are clear: relieve the obstruction, prevent bowel damage such as ischemia or perforation, and address the underlying cause. Step 1. Initial assessment and diagnosis. Let's begin by examining how clinicians approach the initial assessment. The first task is to confirm the diagnosis, gauge its severity, and identify the likely cause. Patients often present with a triad of symptoms: nausea and vomiting, abdominal pain that is crampy or colicky in nature, and noticeable abdominal swelling. Another key sign is obstipation, which is the inability to pass gas or stool and is a hallmark of complete obstruction. On examination, you might detect high-pitched, tinkling bowel sounds in the early stages. Some warning signs suggest a more serious complication, such as strangulation of the bowel. These include persistent, severe, and localized pain, fever, a rapid heart rate, low blood pressure, and signs of peritoneal irritation like abdominal rigidity and rebound tenderness. Laboratory findings such as a high white blood cell count and metabolic acidosis, along with elevated lactate levels, may indicate bowel ischemia. Imaging plays a vital role here. An abdominal X-ray is often the first test, revealing dilated loops of small intestine, fluid levels, and a lack of gas in the colon. However, the real game changer is a computed tomography scan of the abdomen and pelvis, performed with intravenous contrast. This scan confirms the diagnosis, identifies the transition point in the bowel, and pinpoints the cause, whether it is a mass, adhesion, or hernia. It also shows critical signs of compromised bowel, such as thickening of the bowel wall, gas within the bowel wall, or portal venous gas, and can detect closed-loop obstructions that require immediate surgery. Step 2. The management pathway. Once the diagnosis is established, management follows a stepwise approach. Every patient must undergo aggressive initial stabilization. This means nothing is given by mouth, and intravenous fluids are administered to correct dehydration and restore electrolyte balance. A nasogastric tube is inserted to relieve vomiting and abdominal distension, and a urinary catheter helps monitor fluid status. Pain and nausea are managed carefully, and antibiotics are started if there is a suspicion of bowel compromise. The central question now is whether surgery is needed. Some patients require immediate surgery, especially if there are signs of bowel strangulation or perforation, such as peritonitis, shock, or sepsis. In these cases, there is no time for further imaging or conservative measures. Others might need urgent surgery for complete obstruction due to causes that will not resolve without intervention, such as a trapped hernia, a mass, or failure to improve with non-operative management. But not all obstructions require an operation right away. A trial of conservative management is appropriate for patients with partial obstruction, those with adhesive disease without signs of strangulation, or those experiencing an inflammatory cause like a flare of Crohn's disease. During this period, resuscitation and nasogastric decompression continue, with close monitoring of abdominal examinations and vital signs. Success is signaled by the passage of gas or stool and a decrease in nasogastric tube output. Sometimes, a water-soluble contrast study is performed, which can both help diagnose and potentially resolve the obstruction. If the contrast reaches the colon within 24 hours, there is a high chance of success with conservative management. This trial typically lasts 48 to 72 hours. If there is no improvement, surgery becomes necessary. Step 3. Surgical intervention. If surgery is indicated, the aim is to relieve the obstruction and remove any damaged or non-viable bowel. The procedure usually involves opening the abdomen, either through traditional surgery or laparoscopy. The surgeon locates the point of obstruction, addresses the cause, such as dividing adhesions, repairing a hernia, or removing a gallstone, and assesses the viability of the bowel. Healthy bowel appears pink, moves, and has a good blood supply, while unhealthy segments must be removed and the healthy ends rejoined. Special considerations and causes. Let's touch on some important causes and special situations. Adhesions are the leading cause, and whenever possible, they are managed without surgery. However, if surgery is needed, Cutting the adhesions can cure the problem but may lead to future adhesions. Hernias, whether inguinal, femoral, or incisional, require surgical repair. Malignant tumors can also cause obstruction, often through external compression, and may require removal or bypass. For patients with Crohn's disease, medical management is preferred, with surgery reserved for cases that do not respond to medication. Gallstone ileus is a rare cause, where a large gallstone blocks the intestine after passing from the gallbladder, and treatment involves removing the stone and sometimes further surgery later. Final thoughts in summary. Managing small bowel obstruction is a dynamic process that depends on early stabilization and the careful distinction between simple and complicated obstruction. Initial treatment always involves fluids and nasogastric decompression, with the decision to operate based on clinical signs and the failure of a brief trial of conservative management. Imaging, especially computed tomography, is invaluable in guiding these decisions. For the common adhesive obstruction without warning signs, a 48 to 72 hour trial of non-operative management is both safe and often effective. Thank you for joining us for this comprehensive discussion on small bowel obstruction. Stay tuned for more expert insights on surgical emergencies and patient care. If you enjoy our content, please like, share and hit the subscribe button. It's the Everything Surgery Podcast. Dissect the extraordinary.